Next, we'll discuss hypopituitarism or panhypopituitarism, also known as panhypopit. This is a condition in which there is undersecretion of all pituitary hormones. Therefore, patients require treatment with hormone replacement therapy. Causes of hypopituitarism include a non-secreting pituitary adenoma, which is overall the most common cause, as shown here, craniopharyngiomas, Sheehan syndrome, empty sella syndrome, brain injury, pituitary apoplexy or hemorrhage, and lastly, radiation damage. So let's go through these in more detail. You should associate Sheehan syndrome with women after childbirth. During pregnancy, the anterior pituitary enlarges, but its blood supply does not. If during childbirth, the mother loses significant amounts of blood, then the pituitary stalk is at risk for ischemia. Most commonly, the anterior pituitary is affected. So, in that case, what hormones will the patient still be able to secrete? Right, ADH and oxytocin, since the posterior pituitary is still intact. Now, how will you be tested on this? Well, you're going to get a story of a woman who went through childbirth and had significant amounts of blood loss, requiring multiple blood transfusions, and now, a few days into her postpartum period, she has noted that she's stopped lactating. The treatment for this is long-term glucocorticoids, thyroid hormone, sex steroids, and possibly human growth hormone, since the stimuli for the production of these hormones are no longer being released. Empty sella syndrome is exactly what it sounds like. You'll be presented with a patient who is having symptoms of some hormonal insufficiency, and you do an MRI, and what do you know? The sella is completely empty. This can occur if there is atrophy or compression of the gland, and often the cause is unknown. But it is more likely to occur in obese women, and keep in mind that a patient who has Sheehan syndrome will also have this empty sella, but you'll also have the history of a massive blood loss during pregnancy that will help you make the right diagnosis. Hemorrhage into the pituitary gland, also known as pituitary apoplexy, is usually caused by a pre-existing pituitary tumor. The patient will present with a severe headache, double vision, and even bitemporal hemianopsia. This is known as an endocrine emergency, and immediate glucocorticoids must be given to these patients. On the boards, you'll be guaranteed to see a number of questions on the topic of diabetes mellitus. For simplicity, I'll often refer to diabetes mellitus as diabetes, so don't confuse this as diabetes insipidus. We'll start off by reviewing some basic principles of type 1 diabetes. As you may remember, this is due to insulin deficiency, and when this occurs, a hormone can be present in excess. Do you remember which one? Right, glucagon. This is because insulin normally inhibits glucagon release from alpha cells. The combination of low insulin and high glucagon not only results in decreased glucose uptake into cells, but also increased protein catabolism and lipolysis. High levels of glucose or hyperglycemia over time can be detected in the urine, known as glucoseuria. As part of your pathology review, you should remember that damage to the glomerulus is responsible for the presence of glucoseuria. Specifically, you get non-enzymatic glycosylation of the basement membrane, which causes it to become more permeable. Glycosylation refers to the sugar that is circulating in the blood becoming attached to proteins. And specifically, as there is no enzyme that catalyzes this reaction, it is known as non-enzymatic. Additionally, glucose in the urine causes osmotic drag, or osmotic diuresis. This means that glucose molecules create a gradient such that water is drawn into the renal tubules, leading to polyuria. In addition, with the increase of fatty acids in the blood, ketones are formed. Here's a diagram of the ketone synthesis pathway that we've already reviewed in biochemistry, to just spark your memory. These ketones can be detected in the blood with serum levels of beta-hydroxybutyrate, acetoacetate, and acetone. Typically, beta-hydroxybutyrate are what most labs can measure. We can also find ketones in the urine with a urine dipstick. However, it is important to know that this only detects the presence of acetoacetate. For many patients, particularly young people with type 1 diabetes, the first symptoms they notice are polydipsia, meaning that they are drinking a lot, polyuria, meaning that they are urinating a lot, polyphagia, eating a lot, and lastly, weight loss. Occasionally, patients arrive to the emergency room with diabetic ketoacidosis, also known as DKA, which is much more common in type 1 diabetes than in type 2 diabetes. We will discuss DKA in a few minutes. Type 2 diabetics more typically present with a condition known as hyperosmolar hyperglycemic non-ketotic syndrome, also known as HHNS. HHNS typically presents with hyperglycemia, polyuria, but in this case you don't have ketosis since type 2 diabetics can still produce some insulin, which offsets the effect of glucagon on lipolysis. Patients will present with severe dehydration and even seizures as a consequence of the significant water loss. Remember, when you lose so much water in your blood, it becomes hyperosmolar, and this can lead to shrinking of brain cells, also known as plasmolysis, as they transfer water into the extracellular space in an attempt to maintain homeostasis. Typically, you see serum glucose levels much higher than DKA, often greater than 900, and the serum osmolarity is very high, even greater than 320. You may also get lucky enough where the question stem tells you that this patient has type 2 diabetes already. Now let's consider what happens when you have poorly controlled diabetes for a long time. The basic principle here is micro and macrovascular changes that affect almost every organ. The major organ systems that we consider with diabetes are the eyes, the heart, the vessels, the kidneys, and when you start seeing patients in the clinic, these are the key areas you want to focus on for your physical exam. Let's start with the eyes. Any good physical exam of a patient with diabetes includes a fundoscopic exam. What we see in patients who have poorly controlled diabetes are signs of diabetic retinopathy, and these include retinal hemorrhages, exudates, microaneurysms, and neovascularization. Exudates are these yellow granules that you see in the picture here. Microaneurysms are small balloonings of the retinal arteries. Neovascularization just implies proliferation of the retinal vessels. Of note, if this neovascularization takes place in the anterior chamber of the eye, it could block the outflow path for the aqueous humor. And in this case, you might see what? Right, glaucoma. The underlying mechanism of these changes to the retinal vasculature are due to non-enzymatic glycosylation, which we talked about before. And this happens in the walls of endothelial vessels. Remember, I mentioned this earlier, but the glycosylation refers to the sugar that is circulating in the blood that becomes attached to proteins on the basement membrane. Additionally, poorly controlled diabetics are at risk for cataracts. Do you know what is the mechanism of this? Well, let's start from the beginning. We have glucose in the blood that eventually gets into the lens of the eye. The lens of the eye contains an enzyme called aldose reductase, and this enzyme converts glucose into sorbitol. Now, sorbitol is a sugar that will draw in water, and because the eye does not have the enzyme sorbitol dehydrogenase to break down the excess sorbitol, you get too much water into the lens, and this causes osmotic damage. Of note, the microaneurysms we mentioned in our discussion of the fundoscopic exam are also caused by osmotic damage to the pericytes. Another consequence of non-enzymatic glycosylation is arteriolosclerosis, and this refers to atherosclerosis of smaller arterioles. Do you know specifically where this first starts? So it first starts in the efferent arteriole, and this is somewhat fortunate, as constriction of the efferent arteriole can help maintain GFR. This concept will be discussed in more detail in the renal physiology section. What could you see if you performed a renal biopsy? The answer is Kimmel-Steele-Wilson nodules, which are PAS positive. Remember, PAS, or periodic acid shift, is a type of stain that we can use. Now hopefully we are doing a good job by screening our patients for signs of kidney damage, known as diabetic nephropathy, aka nodular glomerulosclerosis. Do you know what screening tests for evidence of kidney damage should be performed annually on any diabetic? The answer is microalbuminuria, as it is the earliest sign of kidney damage. Additionally, non-enzymatic glycosylation can also affect the larger vessels. This is why diabetics are at increased risk for coronary artery disease, which could lead to a heart attack. Also, they are at increased risk for cerebral vascular disease, which can lead to stroke, and peripheral vascular disease, which can result in poor wound healing or gangrene due to decreased perfusion. In terms of peripheral vascular disease, these patients may develop severe soft tissue or bone infections, most commonly on the feet, which may necessitate amputation. If you have a diabetic patient with osteomyelitis or infection of the bone, what microorganisms should be on your differential? Correct, Pseudomonas. You may even note a green discoloration of the wound, or sense a sweet smell of grapes when you examine the patient. So I hope this reminds you to always examine your diabetic patient's feet. Now you may be thinking, well, if this patient has a cut on his foot, then why didn't he take care of it? Well, it's quite possible he didn't even know he had it. Diabetes, if not controlled, can lead to neuropathy, specifically peripheral neuropathy, and this usually occurs in the feet, where patients first start to lose sensation. Now, how did this neuropathy develop in the first place? Do you know the mechanism? Right, it's due to osmotic damage. Remember how we talked about the formation of cataracts in diabetics? Well, it works the same way. Glucose enters the cell, in this case, Schwann cells, and it is converted by aldose reductase into sorbitol. However, this sorbitol accumulates in excess and acts as an osmotic agent, drawing water into the cells. The result of this is demyelination, and the patient develops sensory and peripheral motor neuropathies. Additionally, this can occur at the level of the autonomic nervous system, resulting in diabetic gastroparesis. And this is where patients have decreased peristalsis of the stomach, and the patient will often complain of early satiety. In addition, erectile dysfunction can occur. Remember, point and shoot is all driven by the autonomic nervous system. Also, we might see orthostatic hypotension and neurogenic bladder, where you have problems voiding completely. Now, how do we diagnose a patient with diabetes? Well, there are 4 diagnostic criteria, of which only one needs to be met. We can look at fasting serum glucose levels. Do you know what is the cutoff for diabetes? Right, 126 or higher, and a normal person typically has less than 100. But anything between 100 and 125 is considered pre-diabetes. The second test we can do is a random plasma glucose, or a 2-hour glucose tolerance test, in which a patient is given a 75-gram load of glucose and the blood sugar is checked 2 hours later. For either of these tests, a value greater than or equal to 200 is considered positive. Thirdly, we can check a hemoglobin A1C. Briefly, what is a hemoglobin A1C? Well, it is measuring the glycosylated hemoglobin, meaning the amount of sugar attached to hemoglobin in red blood cells. Therefore, the more red blood cells are exposed to high levels of glucose, the greater the hemoglobin A1C. Do you remember how long the average red blood cell lives? Approximately 100 to 120 days. So this means that the hemoglobin A1C gives us a good measure of what's been going on for the past 3 months or so. To make the diagnosis of diabetes with hemoglobin A1C, the cutoff is 6.5% or higher. The fourth way to diagnose diabetes is 1 random plasma glucose level of greater than or equal to 200 plus hyperglycemic symptoms such as polyuria, polyphagia, or polydipsia. The caveat to the diagnostic criteria discussed here is that the first 3 discussed require repeat testing, whereas the last one does not.